Thanks for joining me. My name is Adam Kinney, and I'm an occupational therapist and researcher with the Rocky Mountain MIREC and the University of Colorado Anschutz School of Medicine. And today I'll be covering learning health systems and how learning health systems use data to improve real-world rehabilitative care. I'd like to start by acknowledging our contributors: Advancing Research on Disability, Colorado State University, the University of Texas Medical Branch, ICPSR, Cornell University, University of Michigan. Thank you all for making these efforts possible. What I hope to achieve today is to first define a learning health system, describe the essential characteristics of a learning health system, review the learning cycle, which reflects the essential process of a learning health system, and provide illustrative examples of that learning cycle. Now, I just want to emphasize up front that this will be an ankle-deep wade into learning health systems. It's intended to just introduce you all to this concept and hopefully reveal the value that this concept has for improving care delivery and patient outcomes. But there's a lot more, and I'll link to some resources that can help enable you to learn more, but there's a lot more to learn that I won't be able to cover today. As a VA employee, just need to point out that this does not represent the view of the VA or the US government. So to start, what is a learning health system? What was formerly known as the Institute of Medicine defined it as a system in which science, informatics, incentives, and culture are aligned for continuous improvement and innovation, with best practices seamlessly embedded in the delivery process and new knowledge captured as an integral byproduct of the delivery experience. Now let's unpack that a little bit. So what are the essential elements of a learning health system? First, relevant data for patients are securely available as data from which we can learn. So we're not just capturing this data for billing purposes. We actually want to learn from it so we improve our care delivery and improve patient outcomes. Second, knowledge regarding best practice derived from these data are available to inform the decision-making within the health system. This is really important. Learning and quality improvement efforts are routine and intrinsically motivated. So most health systems are capable of engaging in these quality improvement efforts when some kind of an external motivator comes in. So for example, a regulatory body comes to a health system and says, if you don't improve this specific care process, you're in danger of losing your accreditation status. Most health systems will respond to that effort by engaging in quality improvement efforts, targeting that specific care process. What distinguishes a learning health system is these quality improvement efforts are just woven into the fabric of how the health system runs. They're engaged in not because they have to be engaged in, but because those involved in patient care see the value in engaging in those quality improvement efforts. Also, infrastructure, so the technology, policies, and standards form the foundation upon which these learning cycles can be routinely executed. And I'll go into detail about what a learning cycle is in just a moment. And lastly, the culture of the healthcare system enables stakeholders to see value in the above processes, kind of related to what I just said about number 3, that the norms and beliefs of those involved in patient care incentivize quality improvement efforts. Again, not just because they have to be engaged in, but because they are valued by all involved within the health system. So I'd like to introduce the learning cycle, go into depth regarding each of these 3 phases, and then provide illustrative examples of each of these phases. So the data to knowledge phase, that covers transforming data into a form that guides clinical decision-making and quality improvement efforts. Next, the knowledge to performance phase. That's when we implement the knowledge generated through the data to knowledge phase to improve service delivery. And lastly, the performance to data phase. This is when we capture practice-based data to evaluate outcomes of those knowledge to performance efforts. So first, the data to knowledge phase. So first, it's really important that a learning community or a network of patients, caregivers, practitioners, and system leaders is formed that are all committed to addressing a certain problem that the health system is interested in. Now, it's often, the learning community is often formed during the data to knowledge phase, but I just want to point out, and this will probably be apparent as I go through each of the other phases, but the learning community plays an integral role in each of these phases. It's really important. It's very much a stakeholder-driven process. So using available data, the learning community develops operational definitions for constructs relevant to the problem of interest. So this is where it really comes in handy, having some expertise regarding how to use routinely captured data to answer meaningful questions. So, you know, the health system has this problem, has these constructs, maybe it's the care processes or patient outcomes that knows that it's relevant, but this is where it's really important to know how to use the existing data elements routinely captured in health record data or what have you, to actually be able to evaluate these constructs and identify potential areas for improvement. Because analyzing this data, identifying potential areas for improvement can be used by that learning community to develop practice recommendations. So how can we improve the care that through this process we revealed could be improved slightly? So an illustrative example, maybe a learning community is really interested in reducing hospital readmissions. They use electronic health record data to evaluate the specific processes of care that are associated with reduced risk for readmission. So for maybe through their analysis, they find that patients who receive rehabilitative care prior to discharge are less likely to be readmitted. So maybe the learning community uses these results to develop recommendations for service delivery aimed at reducing readmission. So maybe it's a recommendation that prior to discharge, patients are seen by a rehabilitation specialist. Next, the knowledge to performance phase. The learning community designs initiatives that align service delivery with the recommendations derived during the data to knowledge phase. So this is where implementation science comes in real handy. So for those of you who are not familiar, implementation science is the study of methods designed to maximize the uptake of practices into routine care. So the learning community can use implementation research concepts to identify barriers to adopting those practice recommendations and developing strategies that eliminate those barriers and ensure that providers are adopting the recommendations that through the data to knowledge phase we've identified as capable of improving care. So returning to that illustrative example, maybe the learning community identifies that insufficient provider awareness regarding the benefits of rehab potentially prevents some from adopting these recommended practices for hospital readmission. So maybe to promote the adoption of these recommendations, they schedule regular in-services to disseminate educational material to providers within the system. So those providers are aware of, okay, not just these are the recommendations, but this is why we're providing that recommendation. So they're aware of the recommendation and why it's important. And lastly, the performance to data phase. This is where we use data generated through routine care to evaluate whether those initiatives from the knowledge to performance phase are producing the desired impact. So now during the data to knowledge phase, we mentioned that, okay, this expertise regarding using existing data elements to evaluate constructs of interest really comes in handy. It also comes in handy by allowing us to determine, okay, what data elements are we not capturing that may be informative? So we can collaborate with information technology experts and data scientists to modify documentation platforms to make sure we're capturing all the information we need to improve care and patient outcomes. I also just want to emphasize that after the performance data phase is concluded, it does not mean that quality improvement efforts are done. After this, the data to knowledge phase is reinitiated and another learning cycle is engaged in. These quality improvement efforts, as I mentioned in the beginning, are an ongoing iterative process that never really stop. It's a constant quest for improving patient care and outcomes. And returning to that example, the learning community collaborates with IIT experts to ensure that the documentation platform used enables a detailed reflection of rehabilitative care not typically available. So for example, maybe they develop a note template that captures the provision of specific educational topics covered during that rehabilitative care visit. So we can use existing data maybe to compare readmission rates before and after those in-services are implemented. We can also use existing data to determine whether the provision of certain educational topics are especially impactful with respect to reducing readmission rates. So maybe it's, capturing this more detailed data helps us refine those practice recommendations. It's not just having rehab prior to discharge, it's a certain type of rehab, the specific services that can help reduce readmission rates. So that information can be used during the reinitiation of the data to knowledge phase. So maybe there are these persistent areas of improvement, and through this learning cycle, we identified a more refined area for improvement that we can re-engage in those efforts and try to reduce those readmission rates even further. So here are those the contact for the CLDR. Thank you so much for joining me. Just want to reiterate that this was a very cursory review, and please check out the resources I provide in the Learning Health Systems chapter outline, and feel free to contact me with any questions you have. Thank you again.